To the Kanski lecture series, and this is a chapter 2 eyelid part 3. So in this part we are going to discuss about the benign epidermal tumors. So these are the basically the tumors that involve the epidermis, and they are benign. What is benign? That they are not invasive, and they are not separating. So we have a squamous cell papilloma, seborrheic keratosis, which is also known as basal cell papilloma, and actinic keratosis, and that's it for the benign epidermal tumors. So squamous cell papilloma histopathologically in all clinical types is similar, showing finger-like projection of a fibrovascular connective tissue covered by the irregular acanthotic and hyperkeratotic squamous epithelium. So very simple, it is basically the disease in which there will is like a finger-like projections, and in this finger-like projection there will be the fibrovascular connective tissue, and overline which is will be the epidermis, and in the epidermis there will be the acanthotic and hyperkeratotic squamous epithelium. So acanthosis is basically the thickening of the prickle cell layer, and hyperkeratosis is basically the thickening of the keratin layer. Squamous cell papilloma is a very common benign epithelial tumor with a range of a clinical appearance including narrow-based, pedunculated or skin tag, pink broad-based sessile and whitish thread filiform hyperkeratotic lesion similar to the cutaneous horn. The incidence increases with age. Some cases result from the human papilloma virus infection. Treatment usually involves simple excision, but other options include cryotherapy and laser or chemical ablation. So basically, there are three types of the squamous cell papilloma. Number one, it will be like sessile, which is like a broad base. There will be like a skin tag, like which is pedunculated, like narrow pedunculated, broad base, and third is basically like a whitish filiform thread like lesion, and it is usually associated with HPV virus, and treatment is usually you excise it, or you can ablate it, or you can also use laser or chemical ablation. So you can see figure 2.5. So it is showing the squamous cell papilloma. A is showing the histopathology, showing finger-like projection of the fibrovascular connective tissue covered by the irregular acanthotic and hyperkeratotic squamous cell epithelium. B is showing the pedunculated skin tag. It's a pedunculated skin tag. C is showing the sessile lesion, and D is showing hyperkeratotic filiform lesion and cutaneous horn. Seborrheic keratosis. Seborrheic keratosis is also known as a basal cell papilloma. So you can see whenever there is a squamous cell, there will be the basal cell. Histopathology show expansion of the squamous epithelium of the epidermis by the proliferating basal cells, sometimes with the keratin-filled horn or cystic inclusion. Seborrheic keratosis, basal cell papilloma, is extremely common, slowly growing lesion found on the face, trunk, extremities of the elderly individual as a discrete light to dark brown plaque with a febrile, greasy, verrucous surface and a stuck-on appearance. So whenever there is a basal cell papilloma, you will have like a stuck-on appearance, which is a very pathognomic of this. You will see the brownish lesion will be like a greasy in color, and it will be like a broad base type, and it is present in a fair skinned individual. And also one thing is basically in its histopathology, what happens is that uh, there will be the expansion of the squamous epithelium of the epidermis by the proliferating basal cells. So what happens is basically that the basal cells are usually proliferating. Whenever they are proliferating, what they causes the expansion of the overlying uh, epithelium, and in which there can also be the keratin filled horn or cystic inclusion in it. They are frequently numerous. The differential diagnosis included pigmented basal cell carcinoma, nevi, and melanoma. Treatment involves shave biopsy, occasionally simple excision, electrodissection with curettage, laser ablation, cryotherapy with liquid nitrogen, and chemical peeling. So basically, you have to excise such kind of lesion, and you can do it by simply excising it, or you can use curettage, you can ablate it by laser. So you can see figure 2.6. 2.6 is showing the basal cell papilloma. A is showing histopathology, showing an elevated expansion of epidermis with proliferation from the basal cell, and horn cyst and pseudo horn cyst are present. So these are horn cyst and these are pseudo horn cyst, and you can see the expansion of the epithelium by the proliferating basal cells. And it is the clinical appearance which is typically showing the brownish greasy lesion, and it has a stuck on appearance. Remember the stuck on appearance for the basal cell papilloma. Next is the actinic keratosis. Histopathology shows irregular dysplastic epidermis with hyperkeratosis, parakeratosis, and cutaneous horn formation. So these are all the pathologies that we have discussed earlier. What is hyperkeratosis, parakeratosis, and cutaneous horn formation? So you can say that epidermis is having a dysplastic cells. So dysplastic cells mean that the cells are not of normal size and their morphology is distorted. Hyperkeratosis is basically in which there is a thickening of the base thickening of the keratin layer, and parakeratosis is basically the retention of the retention of the nuclei within the is the nuclei into the keratin layer. Actinic solar or senile keratosis is commonly slowly growing lesion that rarely develops on the eyelids. It is typically affect elderly fair-skinned individual on an areas of the sun damaged skin such as forehead and back of the hand, and appear as a hyperkeratotic plaque with distinct borders and a scaly surface that may be fissured. So basically it is a hyperkeratotic lesion. You will see that there is a the lesion is basically scaly. It will have a plaque like formation, but it will have a distinct border. It is also very important why actinic keratosis, because it has a predisposition to the squamous cell carcinoma. Occasionally the lesion is nodular or wart like and may give rise to a cutaneous horn. It has potential thorough for the transformation into the squamous cell carcinoma. Treatment involves biopsy followed by excision or cryotherapy. So I told you earlier that these are the benign lesions, and all you can do is basically excise the tumor itself. So you can see the figure 2.7, and it is showing the actinic keratosis. A is showing the histopathology showing irregular dysplastic epidermis with hyperkeratosis, parakeratosis, and cutaneous horn formation, and B is showing the clinical appearance. So next is basically the benign pigmented lesions. So these are the what we have other was benign epidermal tumors, now benign pigmented lesions. So as the name suggests that they are pigmented lesions, you will see the color in such type of lesion, and these are benign. They are not carcinomatous, and they are not metastasizing. So number one is freckle. Freckle is that like mole. You can in a normal word you can say a mole. A freckle Aphylis phallidis is a small, generally 1 to 5 millimeter brown macule due to increased melanin in the epidermal basal layer, typically in the sun exposed skin. The number of the freckle vary with the level of the sun exposure and can sometimes regress completely. Histopathology show hyperpigmentation of the basal layer of the epidermis with the normal melanocyte population. So the concept is very clear. Basically, it is a macule. So you have to understand definition of the macule. Macule is something that there is a color change, color change of the skin without any induration, thickening, ulceration. It is just like you can say a mole, like it is has a blackish discoloration, but it is not elevated, it is not indurated, it is just a color change. And why it happens, it basically there will be the, that the basal layer of the epidermis has melanin in it. And what happens is that there will be the increased concentration of the melanin in these part, but the number of the melanocytes are normal. So you can see figure 2.8. So 2.8 is showing the freckle. It's very you can say a color change, it is very small. Congenital melanocytic nevi. Congenital nevi are uncommon and histologically resemble their acquired counterparts. They are usually small and of uniform color. Rare variants include kissing or split nevas that involve the upper and lower eyelid and may occasionally contain numerous hair and are very large lesion covering an extensive area of the body. Giant hairy nevus, large lesion have the potential for malignant transformation up to 15%. Treatment, if necessary, involve the complete surgical excision. So basically, the congenital melanocytic nevi is the melanocytes are increased in number, and you can see the deep discoloration or blackish discoloration on that part of the area. And congenital means that they are like developmental and they are from the birth, but and they resemble the acquired counterparts. Acquired counterparts mean that the acquired are usually that you get it after some time, not from the birth. And they are usually small and uniform in color. Basically, the large lesions have the potential for the malignant transformation as well. And if you want to treat it, you will treat it with the complete surgical excision. So you can see figure 2.9 A and B. So this is showing the splits nevi. Splits nevi, you can say that the upper and the lower eyelid have a uh, lesion. And B is showing the splits nevi containing hair. The upper lid also contain the lower lid, and the nevus also contain hair. Acquired melanocytic nevus. Uh, the diagnosis, the clinical appearance, and potential for malignant transformation of nevus is determined by the histological location within a skin. So you can there are different types of the acquired melanocytic nevi depending on the histopathology. It can be junctional, it can be compound, and it can be intradermal, and there can be the certain variants of it. So junctional means, so there is epidermis and dermis. Junctional mean that there is between the epidermis and the dermis there will be the nevus cell. And compound means that both epidermis and the intradermis contain the nevus cell. And intradermal mean only the dermis will contain the nevi cell. Junctional nevi occur in young individual as a commonly brown macule or plaque. So you will also there are certain kinds of difference with it. Let's start with junctional, compound, and with the intradermal. So you know that junctional nevi occur in young individual as a uniformly brown macule or plaque. So it will occur in young individual. It will be like a macule or plaque, means there will be the small elevation, or it can be the simple discoloration. The nevi cell are located at the junction of the epidermis and dermis and have a low potential for malignant transformation. So the cells would contain at the junction of the epidermis and dermis, and it also have a low potential for malignant transformation. Compound nevi occur in middle age as a raised papular lesion. So it will occur in the middle age person, and it will have a raised papule. So young, it will have a middle edge. The shade of the pigment varies from the light tan to dark brown, but tend to be uniform throughout. The nevi cells extend from the epidermis into the dermis. It has a low malignant potential related to the junctional component. So basically it also contain the cells in the epidermis and the dermis as well. Both of them contain the nevi cell. Now we have intradermal. Intradermal is basically nevi. The most common typically occur in older patient. It is papillomatous lesion with little or no pigmentation. So intradermal is having the older patient. It will be have a more papillomatous lesion, and nevi cell are confined to the dermis and have no malignant potential. So most of them, the junctional have the most of the malignant potential as compared to other two types. Variants of the nevus include balloon cell nevi, halos nevi, Spitz nevi, juvenile melanoma, dysplastic nevi, atypical null. Multiple dysplastic nevi constitute the dysplastic nevi syndrome, atypical mole syndrome. Individuals with atypical mole syndrome are at risk of developing conjunctival and uveal nevi and cutaneous conjunctival and uveal melanoma. So this is the histopathology showing it. Acquired melanocytic nevi, A is showing a junctional nevus. It is like a macule, and B is showing histopathology showing the heavily pigmented nevus cell at the epidermal and dermal junctions. C is showing compound nevus. D is showing histopathology containing both at the epidermal and dermal junction and within the dermis. E is showing intradermal nevus showing little pigmentation and eccentric lashes. Histopathology showing nevus cell within the dermis separated from the epidermis by the clear zone. Treatment is indicated for the cosmesis, and if the nevus has unusual feature that raises concerns about malignancy, excision should be completed in most cases with at least a 3 mm margin if melanoma is suspected. Benign adnexal tumors. So basically, how you treat the nevus, you do not treat it until it is indicated for the cosmetic purpose or if there is a chance for malignancy. And what you do is you excise, and you also excise with at least 3 mm of the normal margin if the melanoma is suspected. Benign adnexal tumor, that is syringoma and pilometricoma. Syringomas are the benign proliferation arising from the eccrine sweat glands. They are characterized by the small papules that are often multiple and bilateral. So you can see this figure, syringoma. These are the eccrine sweat gland benign proliferation, and they are multiple and bilateral, and they are like a small papules. Pilometricoma or pilometrizoma, calcifying epithelioma of the malherbe, is derived from the germinal metric cell of the hair bulb and is the commonest hair follicle proliferation seen by ophthalmologists. It affects children and young adults and is more common in females. Histopathology shows irregular epithelial island exhibiting variable basophilic cell at the periphery and degenerating shadow cell centrally. So basically, you know that hair bulbs is having a there is a hair bulb, in which the hair follicles and hair is present. So in this there are the germinal matrix cells, and it proliferation of it causes the pilometricoma, and it affects the children and young adults. And in the histopathology, it shows the irregular epithelial island exhibiting viable basophilic cell at the periphery and degenerating shadow cell centrally. So these are the degenerating shadow cells, and these are the basophilic cells at the periphery. Clinically appear as a mobile purplish dermal nodule that may have a hard consistency due to calcification. Calcification is frequently present, and there is often a foreign body giant cell reaction. Malignant change is rare. The lesion is usually removed surgically. Other less common disorders of the hair follicle proliferation include trifolliculoma, trichoepithelioma and tricholimoma. So this is how it present. Clinical appearance, it is like a hard consistency, purplish nodule, and you treat it, there is a calcification present, and that is why it is hard, and you remove it surgically. And other types of the hair proliferation disorders are trichofolliculoma, trichoepithelioma, and tricholimoma. So that's it for the eyelid part 3. See you in the next lecture.